Hello, and welcome to the New Patient Seminar. We like to start our new patients at this spot so that we can talk about all of the wonderful things that can happen with bariatric surgery, but also potentially the bad things that can happen with bariatric surgery, so that you go into this with your eyes wide open, knowing what to expect throughout the entire process. So I want to take this opportunity to thank you for joining us today, and I hope you enjoy the seminar. Let's jump right in. So just a little bit of background about the Better Way Center. The practice was started in 2012, and we now have two surgeons in the practice. Dr. Jagan Gopal joined us a couple of years ago, and you'll get to meet him here in just a little bit. We are two surgeons in the practice, and importantly, we both live here right in Corpus Christi. Why is that important? Well, we're here to serve you both before, during, and after your operation. You don't have to worry whether somebody's going to be able to take care of you. One of us is always here to provide that service. Just a little bit about myself to start. My name is Dr. Lloyd Stegeman. I did my medical school training in Houston, and then I did my surgical residency in San Antonio. I came out in practice in 2003. I practiced in San Antonio for about 10 years before I moved the practice down here to Corpus Christi. I am board certified in general surgery, but I no longer do general surgery. I pretty much specialize in bariatric surgery, now makes up about 95 to 96% of my practice. And I have done a lot of bariatric surgery. I've personally performed over 2,000 bariatric operations, and I've stayed very involved both on the state level and on the national level in trying to help patients with bariatric surgery and try to get coverage for bariatric surgery and fight for the rights of individuals who struggle with their weight. And now I'd like to introduce you to my partner, Dr. Jagan Gopal.
Welcome, my name is Jagan Gopal, and I'm a bariatric surgeon here at the Better Way Center.
One of the great things about our practice is that all of our operations are performed right here in Corpus Christi. It's fantastic for you not to have to go to outside areas. It makes it easier for your family to visit you here in the hospital, and also makes it easier for you when it's time to go to surgery. Our office has extensive experience in getting you prepared for surgery, working with your insurance company to get your surgery covered, and then taking care of you after the operation. And again, all of these visits are done right here in Corpus Christi. You may be wondering if you even qualify for bariatric surgery. Well, qualifying for bariatric surgery in large part has to do with your body mass index, or your BMI. Your body mass index is a ratio of your weight and your height, and once we know your body mass index, we can start putting that into some categories. If you'll look at this chart here, you can figure out what your body mass index is. If your height is 66 inches and you follow across, your weight is 204 pounds. If you follow that up, the body mass index would be 34. So just take a second and see if you can find what your body mass index is. Once we know your body mass index, we can start to put you into a weight classification. People that are obese will fall into a BMI category above 30. BMIs above 35 are class 2 obesity, and BMIs above 40 are considered class 3 obesity. To qualify for bariatric surgery in general, an individual would have to have a body mass index above 35. Now, this is not a hard and fast rule, and sometimes there are exceptions to this, but in general, individuals that seek bariatric surgery would be above a BMI of 35. Now, I'd like to discuss with you for a little bit just about the weight problems that we're having here in the United States. This map shows obesity trends in the United States. As you see, the blues, individuals in that state would have a body mass index above 10%. As you start to see the yellows and the oranges coming in, individuals in that state, 25% of those individuals would have a body mass index above 30 or obese. As you start to get into the reds, now 30% of the people living in that state would have obesity. As you can clearly see, the problem continues to get worse. And if we look at the most recent numbers here in the United States, almost 40% of adults have a body mass index above 30, or at least class 1 obesity. And the really scary part for us is that for quite a number of years, we saw the obesity rate in children and adolescents level off, but unfortunately that is again on the rise, and almost 20% of our children fall into the obese category. Well, how are we doing here in Corpus Christi? Well, unfortunately not great. If we look at Men's Health magazine, where they name yearly the America's 10 fattest and leanest cities, in 2015, Corpus Christi topped the list as America's fattest city. And you can see a number of other Texas cities fall on that list as well. We have a significant problem here in the state of Texas. So what's the big deal about carrying extra weight? Why do we really care about it? It is not the cosmetic effect of that weight. It's what that weight does to your health, and it has a significant and profound impact on your health. Here is a slide showing just some of the medical issues that are directly related to weight. Many you've probably heard of, like diabetes or high blood pressure, but there's also several that you probably haven't heard about or didn't know they were associated. Things like ovarian cancer, endometrial cancer, gallbladder problems, asthma, and even some issues with Alzheimer's disease we know are linked to obesity. In fact, over 236 different medical conditions are directly related to your weight. The good news is that as weight improves, many of these issues are going to get significantly better, if not go away altogether. Well, certainly we know obesity causes health problems, but it also causes life problems. It simply makes it more difficult to do the things that you enjoy doing, and the simple things become much, much harder. We certainly know individuals who struggle with their weight are affected by weight bias and discrimination, not only in the workplace, where they're less likely to get hired, less likely to be promoted in their job, more likely to get fired versus their normal weight counterparts, but also in the marketplace. We can see that by looking at trying to ride on an airplane, trying to get into an airline bathroom, turnstiles, trying to ride an amusement at an amusement park, getting on the roller coaster. Simple things like that become much more difficult as weight goes up. You may have asked yourself in the past, well, why can't I lose weight? Well, the good news is you can lose weight. In fact, weight loss is not particularly difficult. What is really hard is maintaining that weight loss once you've taken it off. Have any of you ever experienced the lose 5 and then gain 7, or maybe lose 10 but then gain 15? In fact, almost every patient that comes to see us has dieted their way up to the point that a bariatric operation ends up being their best option. Well, yes, I can lose weight, but why can't I keep it off? This is really a big change that we've seen in the last 7 years as our understanding of obesity has become much, much clearer. I'd like you to watch this video that puts this concept into some simple terms that I think you'll really find interesting.
Let me introduce you to Amanda. You're just meeting her for the first time, but chances are you're already making assumptions about how much she eats and how little she exercises because she's obese. But I'm about to show you that there's much more than meets the eye when it comes to obesity. There are lots of Amandas out there, and they need treatment. Maybe you're one of them, or maybe you know an Amanda. It's time to act on obesity. But in order to do so effectively, we need to understand obesity. It's generally accepted that body weight is determined by a pretty simple formula. We call it the energy balance equation, and it works like this. If the number of calories that you consume equals the number of calories that you burn, your weight remains the same. If you consume more than you burn, you gain weight. And if you burn more than you consume, you lose weight. Most people think that those of us who properly manage our energy balance remain lean, whereas those of us, like Amanda, who eat too much and exercise too little, become obese. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This may sound logical, but it's wrong. Let me explain. First, let's talk about set point. No, I'm not talking about the point in a tennis match when one player is about to beat the other. I'm talking about a theory that says that no matter what you consciously want your weight to be, your brain has its own sense of how much body fat it should have on board, and it has a complex system in place that very precisely regulates your energy intake and expenditure to keep you within a so-called set point range for body fat. So that whole energy balance equation, it's not something that you control voluntarily. Your brain regulates your calories in to your calories out for you. For your brain to do this, it needs to know how much energy you have on board at all times. And it knows this by listening to hormones like leptin, which is made in your body fat. You can think of it like a car. Leptin is the gas gauge that tells your brain how much gas is in your tank. But leptin is just one piece of the puzzle. You've got a whole bunch of other hormonal signals and sensors that are involved too. Your bones, muscles, pancreas, liver, GI tract and sensory organs, they all play a role, communicating with your brain to give it the information it needs to do its job. But that's more detail than we need for this conversation. The point is that you have a complex system in place that regulates you to within a set point range for body fat. So what happens if Amanda decides to lose weight by going on a diet? After all, people with obesity should eat less, right? Here's what happens. She loses weight, but her hormone levels change. Her brain hears this, and it starts acting to restore whatever body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning fewer calories than before. You see, set point is usually a one-way street. Once it's been elevated, the brain works to defend it, just as vigorously as it would a lower set point. Amanda's brain doesn't know that she needs to lose weight. It only knows to defend her current set point. Back to our car analogy. Amanda can't help but look for a gas station to refuel when she sees that her gas gauge is low. At the same time, she becomes more fuel efficient, burning less energy than before. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda that she needs to be a more careful driver, when the real problem is that she needs a mechanic to fix her car. Okay, so if we've all got this complicated system in place that prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? How can we explain the obesity epidemic? Getting back to Amanda, why did she develop obesity? The answer is that it takes a perfect storm to cause an obesity epidemic like the one we're seeing now, and it's our modern environment that places us, and Amanda, directly in the path of that storm. While there's no single cause for the rising rate of obesity, changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that promote weight gain all play a role. Our unique genetics and developmental histories cause each of us to respond differently to these elements of the modern environment, and some of us, like Amanda, respond by sending hormonal signals that elevate our set point for body fat. It's not that Amanda's system has stopped working, it's just that it's working to regulate her to a set point that's too high. So you can think of obesity as a biological response to the modern environment, a disease where the body dysregulates to a body fat set point that is too high. Back to our car analogy. The size of Amanda's gas tank has expanded, so she carries around too much fuel. It's time to stop blaming Amanda for her obesity. It's time to recognize that obesity is a disease, not a lifestyle choice, and those who suffer from it deserve treatment, not snap judgment. It's time to act on obesity.
Interesting, isn't it? Did you know those things? It really is a change the way that we approach weight loss and even bariatric surgery here in the last 5 years as we gain a better understanding of why it is that people struggle with their weight. We know so much more about the hunger hormones that exist in our body and what happens when we try to go on a diet. Our body's response to that, again, is to try to slow things down. Our body continually tries to pull us back to that weight that we originally started at. So let's take this gentleman right here, Mr. I Beat Anorexia. What is the likelihood that this gentleman's going to be able to lose and maintain a significant amount of weight for 5 years if he starts on the best medical therapy available today? Well, unfortunately, in the vast majority of studies, it's only going to be about 1 to 2% of individuals above a body mass index of 40, again at that severe obese range, that are going to be able to lose that weight on their own. But what if we take this exact same gentleman and we do a bariatric operation on him today? What's the likelihood that he's going to lose a significant amount of weight and keep it off for more than 5 years? That number is greater than 70%. Well, you may be asking yourself now, well, why is it that surgery patients can take their weight off and keep it off, but medical weight loss is so often unsuccessful? What we know about bariatric surgery today is it's not all about malabsorption and restriction, all of those things that we've been taught for a long time. It's the metabolic changes that occur in the body after these operations. All of the different things that occur after the operation that appear to get the body to reset from the weight that you're starting at down to the lower weight after operation, and your body goes back to protecting this newer, healthier weight. It's the only way we know how to do that today. So for those with class 2 and class 3 obesity, those who are eligible for bariatric surgery, certainly bariatric surgery represents the most likely way they're going to get back and maintain a healthier weight. Is it the only way? Absolutely not. 1 to 2% of individuals will be able to get back and maintain that healthier weight for the rest of their life. But if you fall into that 98 to 99% of people who haven't been able to do it on your own, bariatric surgery offers you the best opportunity to get back to a healthier weight. So for all of those who might be telling you you're taking the easy way out, I would completely disagree. I would say you're taking the most effective way out for the problem that you have. Tell me about my options. What are the things that are available for me here at the Better Way Center? Well, I'm going to turn it over to my partner, Dr. Gopal, who's going to take you through the different options that we have here.
At our program, we have a wide range of procedures, including endoscopic and surgical procedures. The newest and most talked about procedures are the intergastric balloons. You may have heard of some of these. These are the least invasive procedures. Of the 3 balloons that are approved by the FDA, we do have 2 of them here. The 2 types seen here are the Obalon, which is a capsule that's swallowed, and the reshaped balloon, which is placed by endoscopy, or a long camera placed through the mouth and down the stomach. The FDA guideline says to use this for BMIs or body mass index between 30 to 40, along with weight-related complications from obesity. These balloons do give good portion control, along with minimal metabolic effects to the body. It is a slow and steady weight loss. About 10 to 20% of total body weight loss can be expected, but this is very variable and very dependent on the patient. It can only be used for about 6 months, after which time it does have to be removed. And currently it's not being approved by any insurances. In the case of the Obalon balloon, a large pill connected to a thin tubing is swallowed. When confirmed by X-ray that this pill is entirely in the stomach, air is filled within the tubing, which then expands the pill into a balloon. This essentially takes up the space of the stomach so that we feel full quicker and eat less. Additional balloons are then added every month until 3 balloons are placed in the stomach, thereby taking up more space in the stomach, leading to less amount of food consumed, giving you more weight loss. After about 6 months, all 3 balloons are removed via endoscope, or again, camera through the mouth into the stomach. In the reshaped balloon, an endoscope is used, or camera again, placed down the mouth and into the stomach. Once the stomach is entered, 2 balloons of the reshaped balloon are filled with saline solution. These fluid-filled balloons then take up significant amount of space, thereby making one full, quicker, and eating less. Again, after 6 months, the balloon is emptied and removed out with an endoscope. Listed here are all the surgeries commonly performed in the U.S. The adjustable gastric band, the sleeve gastrectomy, the gastric bypass, and the duodenal switch, also known as the biliopancreatic diversion with duodenal switch. We will briefly discuss the adjustable gastric band. though it is becoming less and less in favor because of its inferior results and numerous complications, all of which we will get into later. That being said, we do not perform this procedure here. If after this seminar and your consultation with us, you still feel like you want to pursue the lap band, we will be more than happy to refer you to a place where it's still being performed. The gastric band will be discussed here briefly, primarily for historical context, but also because many people are walking around with them and they may need to have the band removed or replaced with a better procedure. As with all surgeries, this procedure is done laparoscopically or with small incisions and a camera. The band is a belt-like device that is lined with the balloon on one side. The device is introduced into the abdomen and placed on the upper portion of the stomach, where it is wrapped around the stomach to create a small pouch above the band. The tubing from the balloon is then attached to a port that's fixed on the abdominal wall, deep under the skin. We can now give the patients fills or band adjustments, which involve placing a needle into the skin and accessing the port. The fluid is then added to the port, which in turn fills the tubing and eventually inflates the balloon of the band, thereby making the band tighter against the stomach. With additional fills over time, this will make the patient feel full, easier, and consume less food. There are two types of gastric bands, the lap band and the realized band. They both give good hunger and portion control with minimal metabolic effects, but the weight is a slow and steady weight loss. About 25% of body weight loss can be seen if the procedure works, but this is very variable and is very patient dependent. It is also intensive in that patients must be seen monthly for the first year so that the band is adjusted just right. There are long-term complications that are numerous, and essentially only 3% of the procedures are done these days. There was once a time where almost half the bariatric procedures were lap bands. The sleeve gastrectomy is the most commonly performed bariatric procedure. About 60% of all procedures are the sleeve gastrectomy. Again, 70 to 80% of the stomach is removed. It does give us good hunger and portion control. About 60 to 70% of excess weight can be removed within the first 1 to 1.5 years. So if you have a person that's 100 pounds overweight, they should lose about 60 to 70 pounds of that within the first 1 to 1.5 years. The procedure, again, is not reversible. It is a relatively new procedure compared to the rest, so long-term data is still lacking. We do have a little bit coming in, and of this data, it does show that about 5 to 10% of weight regain can be seen in about 5 years after the surgery. Certainly, if patients aren't adhering to the program or that narrow tube is getting larger, there can be weight regain. But early on, we do see some excellent results in terms of weight loss and comorbidity resolution. In about 20 to 25% of people, there can be heartburn or reflux disease after the surgery, even if they've never had reflux before the surgery. This can typically be controlled with medications, and this is also typically short-lived. Rarely do we need to have another procedure to treat the reflux disease. This procedure can also be used as a first-stage procedure. In someone that has a BMI greater than 70 or is very obese and cannot undergo gastric bypass or the duodenal switch safely, this is a potential option as a first-stage procedure, since it's relatively less technically challenging than the gastric bypass or the duodenal switch. Once they've lost a significant amount of weight with this procedure, yet still need to lose more weight, then they can safely undergo the gastric bypass or the duodenal switch as a second-stage procedure. The stomach typically holds 1 to 1.5 liters on average, but can stretch to hold 3 to 4 times as much. In this operation, we remove about 70 to 80% of the stomach. Mainly the parts that allow the stomach to stretch is removed, in order to create a long and narrow tube. This operation is not reversible, since the portion of the stomach that we cut out is taken out of the body. But as a result, we get good hunger and portion control, so small amounts of food will keep the patient full and satisfied. In a person that's over 100 pounds overweight, we can expect to have them lose 60 to 70 pounds in the first 1.5 years after their operation. In this animation, you will see the start of a laparoscopic surgery, where small incisions are made in order to place ports or trocars, which give us access to the abdomen to pass our long laparoscopic instruments. In the first part of the surgery, we're creating a small gastric pouch at the upper regions of the stomach. This pouch is about the size of an egg. The second part of the surgery involves dividing a segment of small bowel and attaching it to the gastric pouch. The other end of this bowel is then reconnected further down. In this configuration, food bypasses the majority of the stomach and the first parts of the small bowel. The bile and pancreatic juices are made and proceed in their normal pathway and meet up with the food downstream. The gastric bypass has been around since the late 1960s. It is now the second most commonly performed procedure. To many bariatric surgeons, this is still the gold standard of bariatric procedures. There's a gastric pouch that creates restrictions so that we can only consume so much, and then the intestinal bypass creates metabolic and gut hormones so that you stay full longer and get hungry less often. There is a feature called the dumping syndrome that's unique to the gastric bypass. This can be a good thing or a bad thing, depending on your perspective. The dumping syndrome is a collection of symptoms including crampy abdominal pain, rapid heart rate, flushing, nausea, vomiting, and diarrhea, all of which can be very unpleasant and last about 30 minutes. And this typically happens when you consume about 10 grams of sugar or more, or some food or liquid that's very sweet. It is beneficial to some because it keeps them adhered to a strict dietary path. We can expect 35 to 40% of total body weight loss after this procedure, about 1 to 1.5 years after the surgery. This has very reliable and strong metabolic effects. Again, so if your patient is 100 pounds overweight, we can expect to lose about 70 to 80 pounds about 1 to 1.5 years after surgery. The duodenal switch is a combination of the sleeve and an intestinal bypass. It does produce a significant amount of malabsorption. About 40% of total body weight loss can be seen within the first year to 1.5 years. It is very reliable and does have strong metabolic effects. It is, though, among the highest in terms of risk of complications during and after surgery. It is performed by less than 3% of bariatric surgeons. And it is selective for patients with really high BMIs, typically greater than 50, or who have very poorly controlled diabetes. There is a risk of severe malnutrition along with diarrhea that we monitor for after surgery. There is a modified version of this procedure that's less technically challenging called the loop duodenal switch, or SIPS, or single anastomosis duodenal intestinal procedure, but it's considered investigational or experimental and therefore not covered by most insurances. This configuration makes it such that the food doesn't bypass the stomach but now travels through a very narrow stomach and then bypasses a significant large amount of small bowel. So how do these procedures compare to one another? Again, they're all done laparoscopically. They may all take about 1 to 2 hours to perform. The band usually is the quickest procedure. It can be done in an hour or less. The sleeve, about the same time. The bypass typically takes around 1 to 2 hours, and the duodenal switch will take 2 hours a minimum. The band is the only procedure that's done as an outpatient. All the other procedures require an in-hospitalization stay. The sleeve may be 1 to 2 days, the bypass at least 2 days, the duodenal switch typically 2 to 3 days. In terms of time off work, everybody usually takes off about 2 weeks. And again, all of these procedures are done laparoscopically. The only procedures that are reversible, though, are the band and the gastric bypass. In terms of weight loss, again, the band is slow and very variable. The sleeve is more rapid, sometimes variable. The bypass is rapid, reliable, just like the duodenal switch, which is also rapid and reliable. In terms of amount of weight loss, the band produces the least, about 50% excess weight loss or 25% total body weight loss. Again, that's being generous and it's not seen by most band patients. The sleeve comes next with about 60 to 70% excess weight loss or about 30 to 35% total body weight loss. The bypass does a little bit better with about 35 to 40% total body weight loss, and the duodenal switch does the best, producing greater than sometimes 40% of total body weight loss. None of those procedures produce dumping syndrome except for the bypass, as stated earlier, when you consume too much sugar. The duodenal switch, though, does have a lot of fatty diarrhea that can be seen. Usually it may take several weeks to months before bowel movements normalize after that procedure. In terms of follow-up, the band has the most intensive follow-up for the first year, usually once a month for the first year, followed by 2 to 3 times the year after. All the other procedures have about 6 visits the first year, then about twice a year the following years. All of them can produce some vitamin and nutritional deficiencies, so we do recommend vitamins lifelong after the procedures, and only the band requires fills through their subcutaneous port. The intragastric balloons, as stated earlier, is the least invasive of the procedures, though it does have its own risks. Typically, you can see abdominal pain, nausea, and vomiting sometimes early on. This does subside over time, and we can give medications to control a lot of these symptoms. There have been ulcers reported after the surgery. There have been some people with gastric bleeding, gastric outlet obstruction, or bowel obstruction if the balloon deflates and moves on into the small bowel. There have been reports of aspiration pneumonia, balloon migrating, as stated earlier. There can be acute pancreatitis. There can also be poor weight loss and weight regain. Again, the balloon is highly variable and often patient dependent. There have been some esophageal perforations and gastric perforations that's led to death. Not many here in the US, but has been reported elsewhere. All these procedures do have some risk. Our patients, whether they're having bariatric procedures or say a knee replacement or heart surgery, they are at risk for major complications due to their size and underlying comorbidities. On the left, you see general risks that most of our patients can have undergoing any procedure, such as a pulmonary embolus, which is a clot that travels to the lung, can cause shortness of breath and even death if it's large enough. Pneumonias, heart attacks, stroke, kidney failures, and wound infections can be seen in our patient population. Conversion to open is also something that can be seen going from a laparoscopic procedure to an open procedure. Again, we start off laparoscopic in all our procedures, and 95% of the time or more we can stay laparoscopic. Rarely do we need to convert to an open procedure. Gallbladder disease can be seen in majority of our patients. There used to be a time when the gallbladder was taken out at the same time as the bariatric procedure. Nowadays we're more selective and take out the gallbladder as needed. Vitamin, mineral deficiencies, and malnutrition can be seen in all of our patients, either with any of these procedures, but more so with the gastric bypass or the duodenal switch. Poor weight loss and weight regain can be seen, especially if one doesn't adhere to our program's recommendations. Loose skin is also something that we see in our patients after they've done well with their weight loss. This does not matter if they lost it slowly or rapidly. There's going to be loose skin if they've had adequate weight loss. Unfortunately, people with good collagen or young people have better or less loose skin after weight loss. The only way to really remove loose skin is with surgical resection. There can also be temporary hair loss. This we see sometimes at the 3-month to the 6-month post-op visits. Again, it's temporary as long as patients keep taking their multivitamins and supplements and continue to take their protein. They will return, their hair loss will subside. Finally, death is always a risk. The risk of death is around 0.2%. Some people have a higher risk of death if they have underlying comorbidities like heart failure, COPD, end-stage renal disease, all of which can add to increased mortality risk. But if we can get those patients through the procedure, their safety profile or their risk profile is improved significantly once they lose a significant amount of weight. As stated earlier, the gastric band is going out of favor these days, mainly because of its inferior results, but also because there's numerous complications. About 50% of bands have to come out within the first 5 years due to either failure of weight loss or some kind of band complication. Listed here on top is the slip. The gastric slip just means the band itself has slid down to another portion of the stomach. So now it's either too tight and the patient may be vomiting, unable to consume food, or have terrible reflux disease. The band itself can eat away into the stomach. This is called an erosion and can be an emergency if this is found. That requires removal and repair of the stomach. The next set of complications are system complications, meaning there's something wrong with the tubing or the port. If the port flips, which it can happen, it's no longer accessible. So that needs an operation to readjust the port. The port can dislocate from the tubing, and then the band can empty and it's no longer accessible. Again, this will require an operation to repair. The tube itself can kink, such that now we can fill the band, but we can't empty the band. Again, this would require an operation. And if the needle misses the port and hits the tubing itself, the tubing now has a hole. It will leak and no longer keep fluid in the band. This also needs to be repaired in the operating room. Additional risks include pouch dilation and esophageal dilation. I tell my patient to think of the gastric band as wrapping around a balloon. Squeeze it hard enough, everything above the band starts to dilate. If the pouch and esophagus do dilate, there can be effects in terms of the motility of the esophagus. The esophagus is meant to propel food down from the mouth into the stomach. If it gets so dilated to the point where its nerves are no longer functioning, the food will feel like it's getting stuck into a patient's chest and not really moving down. This can also show up in the form of reflux disease. This, and for all the other reasons listed, are one of the primary reasons most people don't even perform this procedure and may need to have their band taken out. Listed here are the risks for sleeve gastrectomy. The most serious complication is a leak. A leak is when gastric juices or intestinal juices come out of the staple line. This can lead to a profound septic response and need to be addressed immediately. We do test for a leak while in the OR before we finish the procedure, but regardless, there may be a leak within the first few days. But it's not unusual to see a leak weeks on after the surgery is performed. If caught early enough, we may have to go back to the operating room to fix this. If found in a delayed fashion, usually stenting or drainage is required. Another risk is bleeding. Bleeding, not very common, but can be seen after this surgery. Typically with all these procedures, we may lose about 3 to 4 teaspoons worth of blood. So it's not to the extent that we're needing blood transfusions. We can also see a stricture, which is a narrowing of the lumen of the stomach. This sometimes can get better on its own, or sometimes may require us to do an endoscope or a camera down through the mouth and into the stomach to stretch it open. Rarely do we need to convert the sleeve into a bypass if there's a significant stricture. Sometimes the sleeve can rotate on itself and create a twist, which is essentially another obstruction, and that would require a return to the operating room to fix. Not commonly seen though. Reflux disease can be seen. I mentioned this earlier, and about 20 to 25% of people can have reflux, which is acid contents or even bile contents that are washing up into the esophagus causing heartburn. This can typically be treated with medications and usually improves with additional weight loss. Rarely do we need to convert the sleeve to a gastric bypass to treat the reflux disease. Ulcers can be seen in patients who are taking a lot of NSAIDs or smoking, but typically we can treat this as well with medications. A dilation of the sleeve can be seen over time. If people aren't adhering to the dietary recommendations or eating too much, the narrow tube can now enlarge over time, and this can lead to weight regain. On this slide, you see the risks for the gastric bypass. Again, we worry about the leak at the staple line or the connections. This form of leak usually shows up within the first 2 to 3 days, and again, needs to be addressed in the operating room. This too we check for in the operating room before we are finished with the procedure. Bleeding, again, is not something that we commonly encounter and is minimal at most. Bowel obstruction can be seen after this procedure. There have been cases where people ate solid food too soon after surgery and got one of their limbs obstructed and needed to go back to the operating room. There have been cases where blood has bled into the lumen of the bowels, clotted off, and formed a bowel obstruction, again, needing operative intervention. Ulcers can be seen in this procedure more often than the others. This can be seen at the gastric pouch or just beyond the gastric pouch into the small bowel. Ulcers can cause bleeding, pain, and perforation, and can even lead to a septic response. Again, another reason not to smoke or take any NSAIDs after this procedure. Strictures or narrowing can be seen primarily at the connection where the stomach and the small bowel meet. That opening is about the size of a quarter. When it starts to shrink down to the size of a nickel or a dime, that's when we start seeing effects of nausea, vomiting, inability to consume their diet. This can be treated with an endoscope or a camera down the mouth and into the stomach and stretch open that narrowing. Internal hernias is something that's unique to the gastric bypass. It was more of a problem in the past. These days, we have maneuvers or procedures in place at the time of the operation to prevent internal hernias from forming. Nutritional issues are more of a concern with the gastric bypass and the duodenal switch, especially if the patient is not adhering to the program's recommendations. And this is because this is a malabsorptive regarding the duodenal switch and the gastric bypass, because we are skipping a good portion of small bowel that absorbs most of our foods. Listed here are the risks for the duodenal switch. It is a combination of the sleeve and the gastric bypass, so the risks are also very similar. Again, leaking can be seen along with bleeding, along with bowel obstruction or stricture, and internal hernias. What is more concerning with the duodenal switch are the severe malnutrition and severe vitamin deficiencies. The 30-day complications after all these procedures are anywhere from 5 to 7%. The national mortality rate is around 0.1 to 0.2%. Again, the risk of death and complications are very patient dependent. Depends on what kind of medical problems they have, along with how bad their diabetes is, if they have heart issues, severe kidney failure, or on oxygen for their lungs. These days, the current bariatric surgery mortality or complication rate is equivalent, if not better, than a gallbladder surgery done laparoscopically, and mainly because we do the gastric bypass also in a laparoscopic fashion. Listed here are all the improvements you can see after bariatric surgery. Since obesity affects just about every organ in the body, when we can lose enough weight with the surgery, we see improvements just about everywhere, from cardiovascular disease, fatty liver disease, reflux disease, to metabolic syndrome, diabetes, all improve significantly after surgery. Not to mention that quality of life is significantly improved, and that's harder to quantify, but most people feel more energetic, they're more active and mobile, they can breathe better, so their overall quality of life improves significantly as well. So specifically, improvements in diabetes, blood pressure and cholesterol, and sleep apnea and GERD or reflux disease are described here pertaining to each procedure. So with regards to the diabetes, by far, duodenal switch and the gastric bypass outperforms the sleeve and the band. High blood pressure, again, duodenal switch and the gastric bypass, but also the sleeve and somewhat the gastric band can also make improvements there. In regards to cholesterol levels, again, duodenal switch and the gastric bypass outperforms the sleeve, which does have some significant improvements as well, which is better than the gastric band. With regards to sleep apnea, again, the sleeve, gastric bypass, and the dual switch outperform the gastric band in terms of sleep apnea improvements. And lastly, with regards to reflux disease, the gastric bypass outperforms all of them. In fact, for most patients that are over a BMI of 35, this is now the standard treatment for reflux disease. And again, not to forget, quality of life is significantly improved after these surgeries. Thank you for your attention and time. I hope to meet all of you real soon. Dr. Stegman will discuss where the real work begins.
Great. Well, thank you, Dr. Gopal, for going over those different options. Well, now I want to take you through what life is like after your operation. And when we leave that operating room, that's really where the work starts. In the operating room, I often say we work from the shoulders down, but after the operation, we really have to work from the shoulders up. And it's not until we get all of those things in alignment that we truly see patients be successful long-term. So let's talk about some of the things that you can expect after the operation. We really work in a team. It is not just the surgery, it's surgery plus lifestyle change. And we have several team members that are going to help you with that. So we certainly work with nutritionists, we work with some behavioral health experts, we have some exercise personnel that we also work with to get you to really work into leading a healthier lifestyle, which is what helps keep the weight off long term. There are only 5 known causes of weight gain. Those are dietary intake, both solids and liquids, your physical activity, both your exercise activity and just your normal running around daily activities, how you manage your stress, how you manage your sleep, and medications. Guess what? After surgery, those are the exact same reasons. And so we have to create a good plan for you in all 5 of those areas if we're going to see you be successful long term. And that's why the follow-up is so critical. Making sure you're coming in for your regular visits as we work through the program to set you up for long-term success. To be successful after bariatric surgery certainly takes commitment, and it's really a commitment to develop healthy, sustainable eating habits, to engage in regular physical activity. And again, we don't necessarily need you running marathons, but we need you increasing your daily activity. We want to work on improving your sleep habits, making sure you're getting adequate amounts of sleep, and learning some stress techniques that can help you lower the stress levels in your life. It's important that you actively engage in your follow-up appointments, and we also offer several support groups to help you as you readjust to your new way of living. And then we certainly want you to commit to long-term follow-up. We want to follow you forever, and as long as you will let us follow you, we certainly will continue to follow you to make sure you keep this weight off long-term. So what are some of the dietary changes that we're going to have to make after surgery? We place a big emphasis on starting to recognize, am I hungry? Am I not hungry? Am I satisfied? Have I had enough to eat? In general, there will be a maximum of 3 meals a day with little to no snacking in between. Certainly, we're going to work on starting to slow down when you eat and then stop when you feel full or when you feel satisfied. This becomes much easier after your operation, because if you eat too fast or eat too much, it generally is very uncomfortable or hurts and sometimes leads to vomiting. And so very quickly you'll learn what's the right amount during that meal. I think it's important to understand that you'll basically get back to eating everything that you could before surgery, just smaller portions and really an emphasis on healthier meals. We don't believe in good foods and bad foods at the Better Way Center. We really talk a lot more about good choices and bad choices. And we certainly don't need you to be a perfect eater. None of us need to be perfect eaters. We need to create a sustainable lifestyle that you're going to be able to carry on for the rest of your life. So we don't ask you to do anything extreme. What we really try to work into is a good, healthy eating plan that allows us to achieve your weight loss goals but also maintain good, healthy nutrition. The only foods that we're going to ask you to minimize are carbohydrates. Those are bread, rice, pasta, potatoes, and then sweets. And again, it's not that you can't ever have those things, but we do try to limit those within the dietary plan. An important concept for us is that the calories need to come from food, not from drinks. So we really try to get you to drink 0-calorie liquids. The good news is that today there are lots of different really good tasting 0-calorie liquids that are out there. We also ask you to separate your eating and your drinking. So the pattern will be that you can drink right up until you're ready to eat, but as soon as you take that first bite, we want you to stop drinking. And then you're going to wait about an hour after you finish eating before you start drinking again. This allows the food to stay in the stomach for a longer period of time, which will make you feel full and satisfied between meals. This can also often be one of the more difficult challenges for patients because we're so used to take a bite, take a drink, take a bite, take a drink. But this becomes much easier after surgery when you're eating much smaller amounts and ultimately becomes a habit that you don't even think about anymore. Some of the behavioral changes that we see after surgery are the toughest part of this operation. Most patients come through the surgery with little to no problems. It's really learning to live after the surgery that can become a challenge. And changing habits oftentimes brings about its own set of stress. And again, why support groups are very, very helpful as you go through this. To be around other people who are going through what you're going through is often very helpful. You also have a changing body as you're losing weight, and starting to become accustomed to the new body oftentimes can be challenging for individuals as they go through. Everybody sees the behavioral health specialist before surgery, and we strongly encourage it after surgery as you go through the different changes that you're going to go through. It's important that you begin to understand, why do I eat? Do I eat because I'm hungry, or do I eat because I'm bored, I'm stressed, I'm angry? Those reasons still exist after surgery, but if we're continuing to eat for those reasons after surgery, oftentimes patients are not as successful as they can be. And we're certainly going to be there to help you start to deal with those emotions in a much healthier way. It's important to understand that your relationship with your spouse, your children, your extended family, friends will change after your bariatric operation. Now, and many times these will be in very positive ways, but they can also be in very negative ways, and you need to be aware of this. You want to be prepared. While you are the one going through the operation, it certainly affects your circle of family, of friends, and you want to be aware of that. Our ultimate goal for you is not only to get you to a healthier weight, but we also want to do that by maintaining a good, strong mental health balance. In terms of activity after surgery, generally you're going to be released to do whatever activity you want to do 2 weeks after your operation. And then we really encourage you to find what you like doing and then just go do it. We really want to make increased activity a daily part of our routine. So those things that you've heard before, like parking further away, taking the steps when you can, standing up when you answer the phone, those things really do make a difference. And so we encourage you to add as much activity you can into your normal routine. But then we also need to set aside time where we're doing physical activity or exercise. We really focus on 3 pillars when we talk about an exercise program. That would be strengthening, conditioning, and then flexibility. And a good activity program really should incorporate all of those. And we will work with you to come up with a program that works for you. I think one of the important things for patients to remember is that the more you're active, the more you get away on the dietary side of the equation, again, because you're burning those calories through your exercise. It's often said that surgery is just a tool, and this is absolutely true. Surgery will certainly help control your hunger. It'll help control your portion size as the physiologic changes occur after your operation. But the operation won't make you make good food choices. It's certainly not going to take you out for a walk or make you more physically active. It's not going to make you sleep better. It's not going to make you reduce your stress and sometimes can increase your stress. And it's certainly not going to educate you on different medications that cause weight gain. This is the self-motivation part that patients still need to have after their operation. What's nice with surgery is that you're going to see that all of these changes that you're making are making a significant difference, that you're losing weight, that they're very effective, and now you're going to be able to keep that weight off long term. Ultimately, the success of these operations is up to one individual, and that's you. A couple of special topics and then we'll be done. In terms of smoking, certainly we know individuals who smoke at the time of surgery are at a much higher risk of developing blood clots, infections, pneumonias, and leaks after their operation. After surgery, longer term, individuals who smoke are at high risk for developing ulcers. All of these things are bad. We do not operate on smokers. If you are actively smoking, we are going to need to get you to quit smoking before surgery. Certainly, we're willing to help with that, to help individuals stop smoking before surgery, but we do not operate on active smokers. In terms of vitamins and minerals, after your operation, you will take a multivitamin with iron twice a day, calcium citrate with vitamin D 3 times a day, vitamin B12 underneath your tongue at least once a day. This is an area we just can't compromise on. Not taking your vitamins can have serious long-term consequences. Things like weakening of the bones, osteoporosis, anemias, low blood counts, neuropathies where you get numbness and tingling in your hands or your feet, vision problems, hair loss, a number of problems associated with not taking your vitamins and minerals. Certainly we'll be checking your blood work along the way after surgery to make sure that, again, we're losing this weight in a good, healthy way. If you decide not to follow up with us, and I certainly hope you don't, it is important that you continue to get your blood work checked with a physician at least every 6 months after your operation. Many times I hear people say, I don't know if I want bariatric surgery because I still want to have a baby. Well, you can certainly have a baby after a bariatric operation. In fact, you can actually carry twins. Here's another one of my patients who carry twins. We do ask that you wait 1 year after your operation so that we can make sure that we get you to the lowest weight that you're going to be able to get to. And then certainly you can carry a healthy pregnancy. We again ask you to use some birth control method in that first year. Many women who struggle with their weight have problems with infertility and irregular periods. As the weight goes away, those problems often get better. And in fact, sometimes we see patients get pregnant in that first year. We have always been able to help that patient get through that year. Babies have been fine as well, but it is always best to wait at least 1 year after the operation. We do like to see you prior to conceiving, so that we can check any vitamins and minerals and make sure from a health standpoint you're at a good spot as you go into the pregnancy. And then after you are pregnant, we do like to coordinate with the obstetrician to make sure that we follow you along as well throughout the pregnancy. After your operation, it is important that we avoid a class of medicines known as non-steroidal anti-inflammatory drugs, or NSAIDs. These are medicines like ibuprofen, Advil, Motrin, Aleve, naproxen, aspirin all fall under this category. We need to avoid these after surgery because oftentimes they can cause ulcers, and they tend not to be the ulcers that hurt, they tend to be the ulcers that bleed. So we really try to avoid these after the operation. Certainly Tylenol is fine to take afterwards, but again, really try to avoid the NSAIDs. In terms of follow-up, really is an absolute must. Almost every problem that I can think of associated with bariatric surgery can be prevented with good follow-up. It's our job to recognize those signs and symptoms that come along with some of those problems that can occur. But if we don't see you, we don't get that opportunity to diagnose those problems. And the only really true disasters I've seen after bariatric surgery have been in patients who have not followed up for a long period of time. We want to follow you for life, and we hope you give us that opportunity. If you feel like you're struggling with weight, whether you're 1 year, 2 year, 5 years, 7 years out, please don't struggle alone. That's what we're here for. Many times I feel like I have more to offer the patient who's struggling with their weight again than the ones who's doing wonderful. I want to see both of those groups, but in terms of helping the individual, you're never going to disappoint us if you regain weight. We want you to come back in. It's always easier for us to help you take off 5 pounds than it is 50 pounds. Get in here. Let's figure out what's going on, get it solved, and help you keep this weight off long term. Understand you have a disease of obesity. With bariatric surgery, we can very effectively treat the disease, but ultimately that disease can still get out of control, just like blood pressure can get out of control, heart disease can get out of control. You shouldn't feel ashamed if you see some weight regain. Get back in here, let us figure out what's going on and get it back under control. We find support groups to be very helpful, particularly in this first year after your operation, and we encourage everybody to come to the support group. They are held monthly. We do an educational support group, so oftentimes we'll have a speaker come in to address a particular topic, and then we do some group work within as each individual helps other individuals with problems that they might be having. You may be wondering what the process is from here. In just a moment, one of our friendly staff will come to get you to meet with your surgeon. After your surgeon learns more about your medical history, they're going to come up with 2 checklists. One of those checklists are the requirements that your insurance has in order for you to have surgery, and the other will be a medical checklist. Those things that we need to get done to make sure from a medical standpoint we can get you through this operation safely. So when might you be ready for surgery? Well, in order to be ready for surgery, we need to have 2 things done. The medical checklist needs to be completed, and we need to have an insurance approval. In general, that's going to take 1 month longer than your insurance mandated diet requirement. Some insurances require a 3-month diet before surgery, so that individual in general would be ready by 4 months after their appointment. If your insurance requires a 6-month diet visit, in general, you should be ready within 7 months. About a week before your operation, you'll come visit with your surgeon again for a preoperative class that we hold, and then it's time to go to surgery. And after your surgery, we're going to continue to follow you long term to make sure we get you started on that road to health. Thank you again for coming to our new patient seminar. Please, if you have any questions about anything you've heard in this seminar, make sure you discuss it with your surgeon. Thank you.